Okay, so this is the second part of Module 5, and this is really looking at quality in healthcare and really how it is intimately related to cost of healthcare. Now, it says Chapter 23 and 58. Please check the syllabus to confirm those chapters. I don't think you have those chapters in your ebook, but just go ahead and check. I believe it's Chapter 23 in Marquise and Houston and Chapter 10 in Mason. So we've already talked quite a bit about cost, and so if we talk about quality, we know that in 2000, 98,000 individuals die, accordingly to that statistic, every year from healthcare errors. And the Institute for Healthcare Improvement, their trigger tool puts the number at between 220,000 and 440,000 per year. Now, Health Grades in 2008 said that of the 41 million Medicare patients, records between 2004 and 2006, that this reported 238,337 potentially preventable deaths. So all of this says that our healthcare system is flawed and that the lack of quality is huge and is costing us in more ways than we care to really consider. If the airline industry killed as many people as we did, and well, let me not say we, as many people as our healthcare system did, then there would be a huge outcry. But many people just don't know how large these numbers are. So here's part of the story in terms of the price that we pay for our poor healthcare quality. So if we look at 34 countries in 2013, we were 27th for age standard mortality, 27th for life expectancy, 26th for health life expectancy. We hold the highest rank for obesity among adults, our higher prices for health services and goods, higher use of expensive diagnostic equipment, and more elective surgery. So let's look at this from an organizational level. So knowing that issues surrounding the provision of quality care is really multidimensional, it's important to begin with an examination of the definition of what quality care is. And so here's where the problem begins. So finding a definition that fits stakeholders is a challenge. So the IOM says healthcare quality is the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. Well, outcomes are only one indicator of quality. Staying current with professional knowledge is at best difficult. The measurement and definition of quality care differs among providers and patients. So patients can receive the best possible care with information available, yet poor outcomes can still occur. Poor care may still result in good outcomes. So looking at this, we have to look at finding a definition that will really make sense. So from a policy context, one thing that we've kind of talked about is looking at healthcare being driven from a value versus a volume perspective. And so this hospital value-based purchasing program, or VBP, which was developed through CMS, or Centers for Medicare and Medicaid Services, they reward acute care hospitals with incentive payments for providing high-quality care. So this high-quality care is provided by lowering prices as well. So it requires a lot of transparency and accountability. There is performance measurement standards that have to be adhered to, and also public reporting. And so there's a link here that gives more information. It's actually a fact sheet, and it tells how the program works, and it looks at how hospital performance is measured and scored, and it provides a preview of changes in the future under this program. So I suggest you just take a look at it. So going back to some of the difficulties in defining quality care, there's also this difficulty in measuring it. So if you don't have the same definition, you might have multiple ways of measuring it, which is kind of what we do have. So to make the process effective and efficient, the collection of both quantitative and qualitative data is used along with the systematic process. Now, I want you to look up what quantitative data and qualitative data may mean. I'm not sure if you've had research, but if you haven't, you should be having it. So to give yourself a little heads up, I want you to look up those terms. Anyway, so the process includes three major steps. So you're going to measure this by looking at the criteria or standard that's determined, and then information is collected to determine if the standard is met, and then you have to decide if it's that it can be corrected by education or if there's just another type of corrective action that's necessary. So many organizations use something that's called benchmarking, and benchmarking is a comparison. And what it does is it looks at best case scenario or a high performing organization as its tool of measure. And so the high performing organization sets the standard, and so others can measure themselves by that. So you can measure by looking at their practices and your services against this particular organization or entity. So in terms of the nursing profession, the American Nursing Association has played a key role in really trying to develop standards for the profession. And the ANA publishes numerous standards for nursing practice, and they are regarded as one of the authoritative entities. So some of the statements describe the duties that nurses are expected to perform competently. And of notice is the publication of Nursing Administration. So this kind of looks at what leadership should be. So, and then another effort to establish standards for individual nursing practice is the development of clinical practice guidelines, and this was developed by the Agency for Healthcare Research and Quality. Now, in 1998, AHRQ, that is the Agency for Healthcare Research and Quality, and the U.S. Department of Health, in partnership with the American Medical Association, they launched this National Guideline Clearinghouse. So your text cautions that there's some issues with the guidelines, but it's a free, publicly available, comprehensive database of evidence-based clinical practice guidelines. So your text suggests that the guidelines are endorsed largely on an expert opinion rather than research evidence. So, and there's some conflict of interest with some of these issues inherent with this. You know, we have so many resources in healthcare that sometimes I think we have too many, and we need to kind of come together and work collectively. So anyway, organizational standards outline levels of acceptable practice within an institution. Some of the things that you may be familiar with is a policy and procedure manual, and this should be something that you should live by in terms of your practice. If anything ever happens and you're working in an organization, you should be doing it by the policy. If you question the policy, you need to bring that to the appropriate people. So organizational standards are a way to help us standardize certain things so that we can look at them to determine if we're to develop some criteria for looking at quality. So just like standards are, just like I mentioned, like policies and procedures, they provide us something to measure with. Audits are also tools to capture that information. So audits most commonly used in quality control include outcome and process and structure audits. So there's three of them. So an audit is a systematic examination of a record, a process, structure, or environment to evaluate performance. It can be retrospective, looking at something after the patient receives care, concurrently while the patient is receiving care, or prospectively. So we can look at how the future performance will be affected by some of our current interventions. So now an outcome audit is the end result of care. Here, the assumption is that the outcome accurately demonstrates the quality of care that was provided. These are, of course, quite complex and multifactorial. Traditionally, they measure the quality of hospital care. they don't really look at nursing measures. And if you think about it, you have to wonder why, because nursing-sensitive outcomes are quite an issue for many of our readmissions and our infection rates. So falls, nosocomial infections, pressure ulcers, all of that stuff are nursing-sensitive outcomes, but outcome audits sometimes don't look at that. Now, Florence Nightingale was advocating the evaluation of patient outcomes when she used mortality and morbidity statistics. So Florence Nightingale was way ahead of her game. We just kind of somehow dropped the ball in trying to sort of translate or adapt to what the larger profession meant. So one means of better identifying nursing-sensitive outcomes have been the development of standardized nursing languages. That has been one measure. So what that does is it allows us to provide a consistent terminology so that we're describing and documenting within our assessments and our interventions outcomes utilizing this language. So there are 12 standardized nursing languages that are approved by the ANA, and they're listed in your Marquise and Hudson text on page 553, and I'd like you to take a look at them. So now process audits look at is nursing care, how nursing care is being provided, and it really is looking at if there's a connection between the process of care and quality care. So if there is within our policy to look at fetal heart tones or blood pressures at a certain time based on our policy, we have to look to see are we following the policy, and then we determine if that policy needs to be changed. But if we're not following the policy, then that becomes an issue. And so then that's, again, us not living up to the standard. And then did the patient receive instruction about their newborn during the first postpartum visit? So this is something that we should have done along a critical pathway, which we are trying to measure certain outcomes with. And so if the person didn't do that through an audit, we could find that out. So structure audits really kind of make some assumptions about the environment of practice, and it's usually set by accrediting bodies or the BRN, and it includes looking at how healthcare is delivered and what elements surround the interaction between the patient and the worker, like what is the staffing ratio, what's the mix, what are the waiting times. So that's what would be looked at in a structure audit. So quality improvement is broken down in your text by looking at targeting ongoing and continually improving quality. So your text talks about total quality management or continuous quality improvement. And then it also gives some information about the Toyota Production System, or TPS, which are some quality improvement measures that we're going to discuss briefly. So TQM or CQI is used interchangeably, and it's really based on a philosophy developed by this doctor, Dr. Demi. It's also considered a hallmark of Japanese management, and so basically the assumption is that production and service focus on the individual. So it's heavily customer service enforced, and so quality improvement is considered a never-ending process. Everyone within the organization is a part of it. There's really no central QI department, so there's no real need for crisis management because problems are encountered in a preventative or proactive mode. So these types of organizations that focus on TQM or CQI really empower their employees. They empower them to be risk takers and to be a part of the dialogue about, providing really good service. The Toyota Production System, this now really speaks to the philosophy that everyone in the organization should participate in quality control. So it's a production system built on the complete elimination of waste, and it's really looking at efficiency. So Kaizen means Toyota members seek to continually improve their standard processes and procedures in order to ensure maximum quality, improve efficiency, and eliminate waste. And this is implied to all areas of their particular company. So in healthcare, caregivers are charged with solving problems at